Hi, everyone. Good afternoon. We're going to get started. My name is Caitlin Thompson. I am one of the Education Committee co-chairs of the Functional Neurological Symptom Disorder Special Interest Group through the Society of Pediatric Psychology. My Education Committee co-chair, Devin McNulty, You've all gotten emails from her as we've been preparing for the webinar today. So we are a relatively new SIG, and this is our inaugural webinar that's part of a series that we're going to be hosting. So we welcome all of you today. A couple of housekeeping notes before we get started. For those of you who are members of the Society of Pediatric Psychology, if you are interested in joining the FNSD SIG and still haven't done so, we encourage you to log in through your SPP member portal and join our SIG. We also, for those of you who are part of the SIG, as well as the larger SPP community, we sent out a call not too long ago soliciting information about treatment programs and training programs specifically for youth with FNSD. So if you haven't had a chance to fill out that survey yet and are interested in doing so, I'm going to drop the link in the chat. We really encourage you to do that. We're planning to add lists to our website so that people can better access information about training programs and treatment programs. Also, just a reminder that we are recording the webinar today. If you registered for the webinar, you will get a recording of it automatically afterward. We also have a brief survey we'd love for you to fill out that will go out after the webinar as well. I'm going to turn things over to Devin now so we can get started.
Hi, everyone. Just wanted to briefly introduce our speakers today, who happen to be also the co-founders and current co-chairs of the FNSD Special Interest Group. So first, we have Laurie Thompson, who's a pediatric psychologist at Laurie Children's Hospital and an assistant professor at Northwestern University. She works within both the Pritzker Department of Psychiatry and Behavioral Health and the Division of Neurology. The primary focus of her clinical and academic work is on children and adolescents with functional neurological symptoms, providing treatment at inpatient and time of diagnosis, and running an outpatient FNSD clinic. Our other speaker is Nicole Zahka, a pediatric psychologist at Cincinnati Children's Hospital Medical Center. Her practice specialty is somatic symptoms and provides treatment for outpatients with functional neurological symptom disorder as well as syncope. She is the co-author of Treating Somatic Symptoms in Children and Adolescents. So we're very excited to have this first talk. The only thing I will add is there should be a Q&A section where you can type your questions. We will also try to leave some questions some time for questions at the end. There'll be a slight pause about halfway through when Laurie and Nicole shift sort of for speaking, that we can maybe address any urgent questions. And that's about it. So Laurie, if you want to go ahead and get started.
Hello, everyone. This is our lovely website, so please visit us. Okay, so just to start off, I'm just so thrilled to be here. And Nicole and Devin and I started this special interest group a little over a year ago in response to feeling kind of isolated as providers, trying to treat children with this condition, feeling like there wasn't many resources or many people that we could talk to, that a lot of providers didn't really know very much about this condition. And so we started this special interest group wanting to build a community of people to start talking about it, to build knowledge, to really advance the field. And so we're just so thrilled to start that today. And we're also hoping that this is just the beginning, that we can continue to talk together to move our field forward, to build research, to have many more providers to feel comfortable treating, diagnosing, supporting these kids everywhere they go. So with that note, thank you all for being here, and we're just excited to get started today. So today we're going to talk about an introduction to understanding and treating youth with functional neurological symptom disorder. Financial disclosure, Dr. Zahka is the co-author of Treating Somatic Symptoms in Children and Adolescents. And our learning objectives for today are to describe FNSD and to teach conceptual models behind this diagnosis, and then to help you translate this knowledge into communication about this disorder with families to promote clear understanding and helping them on the path towards symptom resolution. And then also to summarize what we currently know about treatment, but really to set that up for our next webinar, which is going to be Erin Fobian later this summer. So stay tuned. So just to start off, getting everyone on the same page about what this disorder is. It is in the DSM, and it's called Functional Neurological Symptom Disorder. It's previously called conversion disorder, which is why that is in parentheses. We also sometimes call it functional neurologic disorder, FND. But it is one or more symptoms of altered voluntary motor or sensory function in the body. So some key words here, voluntary. It's neurological symptoms that are incompatible. So it's not possible for them to have a neurological medical explanation for these symptoms. And it's not better explained by any other medical condition or mental disorder as well. And it causes clinically significant distress or impairment. And then we describe it just based on what the symptoms look like. So do they look like sort of like seizures? So that means that there's a loss of awareness. Oftentimes the body is shaking. Does it look more like tics? So for instance, tics or tremors are abnormal movements. Is there a change in sensory experience? So sensory loss looks like numbness. Sensory gain can look like tingling or an unusual sensation or some pain. Is there weakness or paralysis, speech or swallowing difficulties? And then mixed symptoms, which is a combination. It's actually the most common. And one really important thing to know, and a lot of people had questions about this, is who diagnoses this? And so even though this is in the DSM, it's diagnosed by physicians, typically neurologists, because it has to be incompatible with a neurological explanation. Sometimes other medical providers like pediatricians or emergency room physicians have enough information to be able to diagnose this as well. However, treatment is provided by psychologists and mental health providers. So it really sits at the intersection between medical and psychological sciences. So some features of this diagnosis, it's about 4 to 12 out of 100,000. It's most common in adolescent females. However, that, it might be partly due to some disparities. We're seeing, much more boys than we used to. There's also racial and ethnic disparities in diagnosis and treatment. So some research coming out suggests that that people of minority backgrounds are actually, just not being diagnosed or not being treated in a timely manner. And it's not that they don't have it. And so that is really concerning. Also, we think of this as rare, and I think a lot of people think it's rare since they haven't heard of it, but it's the second most common diagnosed disorder in neurology clinics and represents 10% of inpatient hospitalizations in neurology. So pretty common. However, you saw the range of ways that symptoms can present. And so patients don't always present to neurology. They might present to a lot of different places. They also, there might be huge variations in terms of intensity of symptoms. They might be, tremors that might be more mild, or they might not be able to walk or have symptoms that resemble seizures, which might send them to the emergency room. And then prognosis is highly variable depending on a lot of factors, primarily the access to good diagnosis, education, and treatment. So physicians, neurologists diagnose this condition. However, mental health providers and anyone who treats these patients really need to be able to help the family understand how the diagnosis was given, and be able to clearly explain why this is a confident diagnosis. And so just to talk through some of the factors that lead to this incompatibility with a medical explanation. So one is that the distribution of symptoms is not possible with a neurological explanation. So for example, this is a dermatome map on the right, which maps out where the different nerves in the spinal cord map onto a sensory map of the body. And so if there was nerve damage, we would expect it to follow a specific pattern based on what nerve was damaged. However, when patients have functional symptoms, their symptoms don't follow this type of expected pattern. So they might have symptoms, numbness, maybe just in their foot or from the knee down. And as you can see, that doesn't map onto specific nerves. Excuse me. So it's not possible for that numbness to be caused by a nerve injury. We also see that there is inconsistency in how the symptoms present in different situations. So again, if there was true nerve damage, the symptoms would be consistent across, people and across different situations. But for instance, I had one patient who had trouble walking, but loved swimming and could still swim. And, she was an excellent swimmer. And so there was real inconsistency between when her symptoms were present and what she could do and what she couldn't do. There's also inconsistency between how they perform based on the type of tasks. So whether something is spontaneous or whether it's commanded, suggesting again this relationship with maybe attention, which we see that the symptoms decrease when someone's distracted and increase when they're paying attention. And then really the gold standard for diagnosis is negative imaging. So things like CT scans of the head, of the spine. And then for anything that looks like seizures, doing a video EEG and capturing the symptoms and showing that there's not an epileptic correlate. So FNSD has been called a lot of things: conversion disorder, FND. Sometimes we call it, based on describing the symptoms like non-epileptic seizure, non-epileptic events, which adds, I think, to some confusion that people have about what it is. And also it's part of a family of related diagnoses related to somatic symptoms and psychological factors affecting the body. So these are some symptoms that or some disorders that are similar. So the impact of this diagnosis on both our healthcare system and on patients and families cannot be overstated. In terms of healthcare utilization, these patients oftentimes, are using the ED and require inpatient stays and perhaps rehab stays. They a lot of times, will have multiple ED visits within, a short period of time as they're trying to, get understanding of their symptoms, maybe as symptoms change. A lot of times, if they don't feel like they really understood the diagnosis or got a good, diagnosis or explanation, they'll go to a different hospital and repeat the same process again with a different set of providers. And then the families themselves, they're suffering. Patients are suffering. They are experiencing very significant, debilitating symptoms that are scary. And a lot of times schools are not comfortable with these kids being at school. And so a lot of times they're sent home. they call the ambulance. And a lot of times kids are on homebound, so they're missing school. Their life is really disrupted. And then also they're at risk for incorrect treatment. So if they don't get the correct diagnosis and good education, sometimes they go on a path of, getting serious seizure medications or invasive tests. So now I'm going to pause and I'm going to switch gears to talking more about understanding conceptualization of what is going on with these patients inside their bodies, that these types of symptoms can develop. And I like to start pretty basic with how we all make sense of our internal information in our bodies, our internal sensations, our physiological data, I call it. And then to think about how FNSD is an exaggeration of some of these normal processes or some of these abnormal processes going awry. So if you would all just take a minute and humor me by checking in with your own bodies for a second and noting what sort of internal sensations you're feeling. So maybe you're, depending on whether you ate lunch or not, maybe your stomach is sending signals of hunger or fullness. Maybe you're tired, you maybe didn't sleep last night very well. And so maybe that is sending some signals in your body related to tension or headache. Maybe, you're feeling a lot of energy and maybe you're feeling that in certain ways in your body. So all of us, all the time, have to sort through a tremendous amount of information in our bodies. This is just a small sample. Our bodies are always collecting data based on how every system is functioning. And as we move through our day, that data changes. Our body has to continually adjust how we're feeling, has to send us signals based on things like hunger and thirst, as that changes throughout the day. How fatigued we are changes throughout the day. And then normally as we move, things like our heart rate changes, our breathing changes. And sometimes these, they get much stronger, have much more intense signals. And so we have to sort through as a body, right? What do we do with all this information? And so we ask ourselves some questions. Things like, what's happening? What's going on in my body? What does this mean? What is important information? What is something that I can ignore? When does it reach the level of it being something wrong? And what do I do about it? And kids also look to the grown-ups in their life for information on how to interpret their own internal signals. So they look at how parents have modeled, reacting to similar situations. They, they look at how their parents are reacting to their own, experiences. Look at their face. And so this creates what I like to think of as a health scaffold, which is all of our kind of internal experiences, influences of our family, the situation, and then internal factors like our emotions, how much attention we're paying, what our thoughts are. And all of that helps our body to interpret and make sense of this data, this raw data from our body. And so the sensations that we experience are not raw data from our body. They are filtered through our brain, which takes into account kind of all of this rich information from our health scaffold. What also happens sometimes to all of us, not just to kids with FNSD, to all of us, is that sometimes our brain relies more on the health scaffold than it does on raw data. And so an example of that is, let's say that you have to give your kid yucky medicine they don't like, and you hold out the spoon with the medicine on it and you say, you got to take this. And the kid starts gagging and is visibly nauseous, right? Your kid is having a physical reaction to not to actual information from their stomach, right? They haven't had it yet, but to past experiences, right? To imagining what that tastes like, to anticipating what that's going to feel like in their bodies. So all of us have sensations that we experience every day that are more related to aspects of our health scaffold than pure data from our bodies. And so what is going on in the brain for kids with FNSD? And how does this relate to some of this disruption and basic, sensory sort of processing and perception that I just talked about? Well, what evidence tells us is that there are some real deficits in certain areas. So for one, there's a decreased sense that the body is under voluntary control. So if you remember earlier, these are voluntary aspects of the nervous system. However, the body is not believing that they're under voluntary control. There's also emotion processing deficits. So for example, that can be too much emotional reactivity, and a heightened physiological startle response or arousal to certain situations. There can also then be kind of an under response, so an avoidance of emotions, kind of an alexithymic reaction of not really knowing what emotion I'm experiencing. And then impaired ability to regulate emotions that do come up. We can't regulate them in a healthy way. Similarly, there's impaired interoception, which is one's ability to map and understand what's going on in one's own body, synthesizing all of this data. So there might be too much monitoring. How am I feeling now? How am I feeling now? What about now? There also might be difficulty, shifting away from the body. There might be also not enough attention paid to certain parts of the body, that they're sort of like being avoided. And then there's too much connection between the emotional state and the physical state. And then lastly, there's an important role of the interpretation of what's going on in the body. So there might be normal internal sensations, sort of like change in heart rate, but there's an interpretation that's catastrophic, that means that something bad's going to happen. That means that I'm sick. And then all of these areas of deficit come together and overlap in ways that create the conditions for FNSD to develop. And this map is complicated. It's really complicated. There's a lot of different areas of deficits that are not necessarily visible. And I like to think about the symptom that we see actually as being just kind of the tip of the iceberg in terms of what is going on in the brain and the areas that the kid is struggling with. So next, I want to talk about the role of stress and trauma. And I think a lot of people have in their mind that this is a primary cause of FNSD. And that is a traditional explanation. And I would say that some patients really respond to that explanation. But only a third of patients do we actually see that have true trauma symptoms. A lot of patients, though, with this condition have had other sort of adverse events like bullying or have had, other medical conditions and maybe medical procedures. And some patients really do connect their symptoms with stress triggers. Like my symptoms always happen when I walk into math class. But a lot of patients don't. And a lot of patients don't have trauma and don't view themselves as having stress. And so for a lot of patients, this is not a helpful explanation. Some things we do see are higher rates of anxiety and depressive symptoms. So not necessarily clinical levels of, major depressive disorder, for instance, but that they're just more anxious and more down than other kids. They're also more somaticizers. They might have a range of other somatic symptoms. And they tend to see that they don't have great coping skills to deal with the issues they are facing. So a lot of times their coping skills are more solitary, more passive. I have one kid whose only coping skill to deal with high school is to sleep. That's all she does. And that's just not a very helpful coping skill. We also see that they have a heightened physiological experience of negative emotions. They might not even be able to verbalize it or describe it, but it's a stronger physiological reaction. So the last model I'm going to talk about is by Fobian and Elliott. And it takes into account a lot of these things that I've been talking about and thinks about this disorder as a result of conditions set by predisposing factors, and then it's maintained by some maintaining factors. So predisposing factors are things we've already talked about, like somatic symptoms, trauma, excess symptom monitoring. And then the reinforcing factors, things that make the symptoms get stuck, are related to secondary gain, getting out of things, connecting with a sick role, finding benefit in that. And then they put it together for this model where they think of functional neurological symptoms as developing, from normal physical symptoms that are misinterpreted and then tied up with kind of an anxious response. And so, a brief example of this is I have a patient who has lost a sibling to cancer. And so if we think about the health scaffold, she has had some really, significant medical experiences and loss. On her way to her first day of school, she had a panic attack. So some physical symptoms there. Then she had trouble walking. She misinterpreted those physical symptoms based on her experiences as perhaps being very dangerous, right? Perhaps being cancer. Her family, also having kind of the same experience as she did, they were also worried about that. And so she got to stay home from school. So that was reinforced because she didn't want to go to a new school. She then, the trouble walking continued. It really stuck around. And she also developed some separation anxiety. And so every time she tried to go to school or leave the house, she would experience this rush of anxiety, some more physical symptoms, more trouble walking. And then she would stay home, it would feel better, and that was reinforced. And so you can see how, just for one example, but how these symptoms are really complicated and how they're influenced by this whole biopsychosocial system. All right, so now we're going to switch over to Nicole, who's going to talk more about how we translate this information into communication with families. And I think we might pause for some questions.
We just have one question in the chat, and I don't know if we want to sort of defer this to the end versus now, but talking about how to different sort of secondary gain versus faking it, especially when you're talking to parents.
That's a really good one. I'm thinking probably that Nicole will talk more about how to talk about this with parents. But I would say that that's not super helpful to talk a lot about, to overly talk about that, but to normalize that, that there are a lot of things that are reinforcing about staying home, and that, symptoms, it is normal for symptoms to be learned, and that it's also okay to help kids go back to school. I'm going to translate over to Nicole now.
Thank you, Laurie. I'm going to talk now kind of translating all of those concepts into practice and sort of how we talk about functional neurological symptoms with patients and families. And then we'll save some time at the end to try and get to some of those questions in more detail. So first, I want to time travel a little bit, and I want to just talk about the historical context to functional neurological symptoms, because I think that this is actually really important in terms of how we are understanding our own biases in diagnosing and treating and talking about functional neurological symptoms with patients and families. And so I think this is pretty important in terms of how we're going to move the field forward. So centuries ago, in the 5th century BCE, Hippocrates coins the term hysteria. And he says that this explains these kinds of symptoms that people are having that are not associated with an underlying disease or injury. And what it gets attributed to, what hysteria gets attributed to, is a wandering uterus. So only women can have these symptoms. And the uterus is wandering around because the woman is not engaged in marriage or in child rearing. And when the uterus bumps into various different parts of the body, that's what causes the symptom, right? So the uterus wanders up to the head and you got a headache. And so just as an interesting point, right? Hysteria as a term is coined in the 5th century BCE and is in our diagnostic manuals until the 1980s, which is really wild. And what happens is, over the centuries, even in the 1800s, for example, that wandering uterus belief is still present. So, women would carry smelling salts in Victorian times, and when they fainted or swooned due to big emotions, smelling salts were used, and that was thought that the uterus found that to be a noxious scent and would return to its place in the pelvis, and then the woman would wake up again. And of course, we now know that the frequency of women swooning in the 1800s was probably much more likely due to the fashion and the corsets kind of constraining their ability to breathe than anything else, right? But I think what this really illustrates is we've had this sort of biased understanding of functional symptoms for quite some time, right? In the 1900s, Freud uses the term conversion disorder, that these symptoms were an emotional conflict that couldn't be resolved, and so they were converted into physical symptoms. Now, of course, we much better understand this biopsychosocial understanding of functional symptoms, which is that, it's really due to physical, emotional, and social and environmental, in the context of kind of genetic and biological and all of these multifactorial reasons that these symptoms could develop and maintain over time. Only in 2022 was conversion disorder placed in parentheses and functional neurological symptom disorder placed as the main diagnostic title in the text revision of the DSM-5. So that is a really long time for us to be using terminology that's actually not particularly lined up with the biopsychosocial approach. And so I think, again, it's really important for us to be aware of this historical context and aware of how that creates bias for us as care providers, and how we can kind of move things forward. In addition to that, the media representation of functional neurological symptoms is fairly terrible, right? So these are just a couple kind of TV shows that have had episodes that are centering around functional neurological symptoms. And so this is what patients are seeing, right? This is what people out in the world are seeing. And TikTok has social media influencers on it who are promoting information, right, that we have no control over, that's not necessarily lined up with state-of-the-art treatment, diagnostic information and treatment for these kinds of symptoms. And interestingly enough, the social media influencer, this trippy hippie, who's someone on TikTok who has tics and other types of functional symptoms, for a time had more followers than Taylor Swift. So since Taylor Swift's new album dropped, now Taylor Swift is back on top again. But I just think it really illustrates the far-reaching information that's out there that truly, as care providers, we don't have as much control over. And so what happens? There's tons of confusion for everybody. There's confusion for providers. There's confusion for families. Everybody's frustrated. It's hard for families to get an accurate diagnosis. They don't necessarily feel heard, right? As Laurie talked about, there's lots of healthcare utilization, not necessarily getting connected with the correct treatment. And providers are frustrated, right? So providers are maybe uncomfortable with the diagnosis, or are comfortable with the diagnosis and not comfortable with talking about the diagnosis. There's worry that patients are taking up resources or feigning their symptoms, right? And I think, what ends up happening is that the whole experience for everybody can be really challenging. And we really want to start thinking about what can we do to change that narrative, right? So oftentimes communication about functional neurological symptoms centers on what their symptoms are not, right? Your non-epileptic seizures are just due to stress. They're not seizures. There's nothing wrong with you. And that, we expect families to be really excited about this information. But the fact of the matter is they're still having the symptoms, right? And kind of tying it to stress doesn't necessarily help. Even though we know that stressors can be associated, right? But a communication about what symptoms are not typically leads to worsening symptoms. And so we have to change the narrative. And this is a great article by John Stone, where, he really centers on how can we explain functional symptoms in a really powerful way, and how can we as providers really practice our explanation and in the way that we say and in the way that we're explaining to families can really be the first step in treatment. So it's not just giving the diagnosis, but it's really starting to get the patient and the family on the road to recovery. So what I really want to focus on is what's the terminology we're using? How can we give a good biopsychosocial explanation, and how can we explain treatment in a way that in a way that makes sense and reassures patients that, again, like Laurie said, the functional symptoms really live at the intersection of medical and psychological science. And because of that, both medical providers and psychologists and mental health providers have to kind of continue to co-treat these patients. So if we're thinking of terminology, medically unexplained, symptoms are stress related, they're psychogenic, pseudo, behavioral. These are all outdated terms that are still used that are not helping us, right? Everybody knows that pseudo means fake. If a patient is diagnosed with pseudo seizures and that's what they see in their after visit summary, or that's what they were told that they have, we're telling them they have fake symptoms, right? But then we're also telling them, no, we believe you, but you should go see the psychologist, right? So even the terminology has to be accurate in order to get patients to understand the diagnosis, understand the treatment, engage in the treatment, and get better, right? So, and again, like psychogenic means it's associated, it's a psychological problem. Behavioral makes it seem like it's under their control, right? Stress related makes it seem like it's just due to anxiety. Unexplained makes it seem like we haven't done enough tests, right? We have to be telling patients, we know your symptoms are real. We're calling them functional symptoms. Functional means that there is not a problem in your body, but there's a problem in how your nervous system is functioning. We are not going to be using these old terms because these old terms are incorrect and related to a biomedical model. We're looking at a biopsychosocial model. And we really want to be modeling inclusive, non-pejorative language with patients and with colleagues. Anybody who knows me will say that if you get stuck in an elevator with me, you're likely to hear how we can talk about functional neurological symptoms in a really patient-forward way. And what I want to be clear about also is this idea of how we're talking about stress, right? So I gave a presentation once, and one of the learners at the presentation said, well, it sounds like you're saying not to ask about stress, but that's a really important question. It is, but I think that the way that we ask about it is more important. So if I ask anyone attending this webinar, what do you feel stressed about? you are going to redefine that in your mind as to what do I feel emotionally stressed about. And if you're coming in with a physical symptom, and maybe this is your, maybe this is your first visit, or maybe this is your 7th visit for your functional symptoms, and somebody asks you what you're stressed about, that is really going to make you feel like your care team isn't listening, right? But if we ask the question in a different way, if we give this good biopsychosocial explanation and we talk about how physical stressors can affect the body, how emotional stressors can affect the body, and how social and environmental stressors can affect the body, and then we say, which types of stressors do you notice in your life? We're getting at the same information in a different way. And in fact, if you think about it, oftentimes, for many of our patients are teenagers, right? The physical stressors of being a teenager in terms of poor sleep, not eating regularly, having to pay attention for 8 hours at school, right? The daily schedule of an adolescent, there are enough physical stressors to set the stage for patients to experience functional neurological symptoms. So I think that, asking about stressors in a different way is really powerful. And then that can kind of lead us into a really great analogy for understanding how the number of stressors can overwhelm the system and cause functional neurological symptoms. So I always say, if you imagine like one of those Gatorade containers, it doesn't have to be branded, right? So if you imagine one of those drink containers that has a spigot at the bottom, and that's our ability to cope. And every time we experience a stressor, it sort of adds some liquid to our container. So maybe, you don't get a good night of sleep. Maybe you have a big test at school. Maybe you have a lot of homework. Maybe you got into a fight with your friends. Maybe the cafeteria is really crowded. Whatever it is, each of those things adds some liquid. And maybe you have some liquid hanging around in there from something that happened before, right? And eventually, if you have enough stressors, that container is going to get full. And if you don't have good coping skills to be able to let some of that liquid out, the system's going to overflow, right? And so the overflow is sort of how you can explain those functional symptoms. This doesn't mean that kids are bad at dealing with stress. It just means sometimes the number of stressors overwhelm the resources at that time, right? So, and it really depends on lots of different factors in the child's life. And again, it could also be that there's an unpredictable big stressor that somebody didn't have the resources to deal with. Maybe their level was already pretty full, and then there was something big that came at them. And so I think this is a really great way, again, to explain physiologically what's happening for patients, and why they're having their symptoms, that really takes that nice biopsychosocial approach. And being able to give a good explanation biologically of what's happening, I think, is really powerful. I feel like very often I talk to people and they say, how do you get buy-in? How do you get patients to come back? And my answer is always, I give a physical explanation for a physical symptom. Patients are coming in with a physical symptom. They are not expecting to be told that they are going to get treatment from a mental health provider. And so we have to bridge that gap in saying, well, let me tell you physically what's going on for you. So the brain and the body are connected by the autonomic nervous system, and the autonomic nervous system kind of controls our speed. We have the sympathetic branches, which is like the body's gas pedal, and the parasympathetic branch, which is like the body's brake pedal. And again, like Laurie said earlier, the brain and the body have a whole range of communications and reactions that are normal and expected to different types of stressors when the body gets activated, right? But again, if we have lots of stressors at one time, or even a really big one, the brain can get mixed up and sort of forget how to slow itself down and remain in a state of activation. And again, this is really multifactorial, and referring back to some of those conceptual models, I think is really powerful, because it's not always just one thing. It's this combination of how is the brain registering different types of stressors? How is it communicating to the body? What is that health scaffolding about, right? And the nervous system has to respond to all of that. So the nervous system gets activated, stays activated. And that's sort of what underlies that experience of functional symptoms. And functional means that symptoms are due to how the nervous system is functioning. They're coming from the sympathetic nervous system being overactivated, the brain misinterpreting stressors, causing these extreme reactions of what is a normal response, and sort of forgetting how to slow itself down. They're not being caused by something wrong in the body. They're not dangerous, but they are being caused by something wrong in how the brain and the body are communicating with each other, right? Again, we're giving patients an understanding of what their symptoms are, right? And this idea of like, you're fine, well, they're not actually fine, right? They're having really significant symptoms. So we have to match patients where they are and say, yes, there is something wrong. It's just not what you thought it was, right? It's really much more about a communication problem and less so about a disease or an injury in the body. We know the body is healthy anatomically, right? And we know the symptoms are real. There is not a limit to the number of times you can say this to the patient, but you also have to believe it yourself. We have to re-engage with our empathy for these patients. We all have somatic symptoms, right? We don't all necessarily have functional neurological symptom disorder, but we all have this somatic symptom experience, right? The symptoms are real. They are not voluntary. Patients are not doing this on purpose. Now, are there times that symptoms get emphasized because patients feel unheard? Sure, absolutely, right? There are for sure times that there are patterns that patients get stuck in where maybe they're not using coping skills that they could use and they're experiencing emphasized symptoms. And much of that emphasis is so that they'll be believed, right? And so families really need to, there was this idea for a really long time that we needed to like unmedicalize functional neurological symptoms and we just shouldn't attend to them at all, right? If you just ignore them, they'll go away. Well, if we remember that functional neurological symptoms are the body's outward reflection of a really overactivated fight or flight response and a really overactivated sympathetic nervous system response, can you imagine being ignored in that situation? And what we really actually need to do is validate that the symptoms are happening, that the child's experience is happening, and encourage coping, right? And teach the coping skills so that the patient has strategies to have control again, so that the patient has strategies to deactivate that nervous system. And the treatment standard, the way that we do that is through cognitive behavioral therapy. And I said a little bit earlier that psychoeducation is really the first step. Giving a good explanation of the diagnosis is the first step, and it is, right? So that is where, that's where treatment can start in office, or in, while patients are inpatient in the hospital. That diagnosis and clear explanation is the first step. And then ongoing cognitive behavioral therapy continues the treatment. So when we're able to change communication to what symptoms are, the types of symptoms you're having are called functional. The symptoms are real. They're due to how your nervous system is functioning, not due to disease or injury. This is good news. There are treatments. It's just not what you might have expected. Patients feel heard. Families feel heard. They feel like there is something that they can do, and we get improving symptoms over time. And the treatment approach really has to focus on function. So if we're pulling from the pain literature, right, we know that function has to improve before pain does. And the same is true for functional neurological symptoms. Function has to improve before symptoms do. So we need to give patients the set of tools, right, the skills through cognitive behavioral therapy to target barriers in each area of the biopsychosocial model. What are the physical strategies that patients can be using? What are the behavioral strategies patients can be using? What are the thinking strategies patients can be using to be able to manage the body response and to be able to manage the anticipation that comes along with that uncomfortable body response, to be able to improve their function over time? And there's a couple different approaches that have been looked at in the literature, right? From an outpatient perspective, psychoeducation, different parts of cognitive behavioral therapy, multidisciplinary referrals as needed to, PT or to psychiatry. There have been inpatient multidisciplinary rehab models that have been looked at with PT, OT therapy, rec therapy, school reintegration plans. And then we're really, really excited in August to have Dr. Ariane Fobian presenting on her retraining and control therapy, which is an evidence-based treatment that helps retrain FND symptoms and increases that sense of control over symptoms. So keep an eye out for that. That's going to be in August. So how does all this help symptoms? Well, the psychoeducation and the good explanation for the diagnosis and why it's happening provides an answer, reduces uncertainty, and gives people a positive pathway for treatment. Physical and behavioral strategies give patients something to do when they have their symptoms or to prevent their symptoms, and helps to deactivate that sympathetic nervous system. Cognitive strategies help patients manage negative thinking, manage emotional distress, and over time lessen symptom intensity and frequency. Parenting strategies help increase positive attention to coping and really kind of change any systemic accidental reinforcement that might be occurring. And in combination, all of this helps retrain the nervous system over time, which means that symptoms are much less likely to occur and patient is able to regain functioning. So again, just a reminder for that, save the date for Dr. Fobian's webinar, August 21st, and I will open things up for questions.
We have a lot of questions in the Q&A. Nicole and Laurie, I will sort of pick some themes, but if you guys want to sort of also look at them as I'm going through them, just to see if there's any you want to prioritize. Unfortunately, you probably won't get to everything. But I think a question that's come up in a couple different ways is sort of how to address both conceptualization and treatment with FNSD co-occurring with other medical diagnoses, whether that's a seizure disorder, someone asked about cancer, and then someone asked about just other somatic complaints like headaches, stomach aches, and vomiting.
I think one of the things that clinically I've done when functional neurological symptoms are co-occurring with something else, for example, functional seizures co-occurring with epileptic seizures, is really, I think, again, that's a great time to collaborate with the other care team and really clarify what are the symptoms that are associated with each presentation and what are the plans that are going to be used to manage each set of symptoms. So for example, what do the epileptic seizures look like? What do the functional seizures look like? What's the plan for the epileptic seizure management? What's the plan for the functional seizure management? And overall, right, and really kind of like laying it out, having both providers sign it so that, for example, obviously at schools are going to have lots of questions about, how are we managing each of these types of symptoms? Having all of that written out, sharing the plan with all of the people that need to have it, having both providers on board. I think it's very challenging for the psychologist only to be in charge of that, right? If we're trying to, we can't be the ones that are determining how to treat an epileptic seizure. And then really also working on prevention. So what are we doing to structure the patient in a way that is leading to better self-monitoring early to prevent the exacerbation of those functional symptoms?
I would also just add briefly that I think this is the norm rather than the exception, that a lot of these kids do have other medical conditions, more, a range of somatic symptoms. They've been exposed to medical, symptoms in their families. And so thinking about how this all relates to the health scaffold too, and the catastrophic thinking that might be occurring around medical symptoms and maybe the over self-monitoring that might naturally happen when you have a chronic condition. And so normalizing and validating a lot of those processes.
There's also quite a few questions about sort of supporting or collaborating with medical providers and giving the diagnosis or resources, scripts. And so I think, while you guys are maybe talking or speaking to that, I know Caitlin has pulled up our website that has a section for resources for clinicians and providers that maybe she can kind of click through and you guys can add to. Specifically just sort of like how do psychology teach, collaborate with respond to when we're being asked to rule in or out a diagnosis of FNSD, those sorts of things.
Yeah, I would really encourage all of the psychologists here not to work in isolation when they're working with these kids, but really to partner with the physician and with a broader medical team to all be on the same page, and to make sure that the diagnosis is given clearly, and that sometimes I help relay questions back to the physician or help clarify answers to the family, but that also that the clear diagnosis does need to come from the physician, and we need to start there before we can provide our treatment. And so we can also do some education and help support our physician colleagues through giving them these kinds of handouts, or giving talks and things like that too.
So yeah, I think given a lot of the questions, the fact sheet for health professionals might be a really helpful one. I don't know, Caitlin, if you're able to download it and if that would work. Otherwise, feel free to check out our website. Everyone should have access to these, whether you're a member of SPP or not. But our website crew worked really hard, and our the other committees of the SIG work really hard on these. So I think these are great. Let's see here. Trying to group questions together. A couple questions about treating or seeing more of these symptoms with patients with either undiagnosed or autism or diagnosed autism. Are you all seeing an overlap maybe in your clinical populations? Quite a few people asked about that.
That was a great question. And somebody also asked about research. I don't know of any research, so I think that is an area that is probably pretty ripe for exploration. And I have not seen this pattern as much, but I think it's certainly clearly, like, quite a few people have mentioned this in the Q&A. And so I think it bears sort of more discussion to see if we can figure out, for folks that are experiencing more functional symptoms, also related to kind of sensory sensitivities, right? That if we think about sensory sensitivities as being a stressor, that the brain and the body are having to deal with, right? It would make sense if that is a fairly kind of chronic symptom for somebody, that it would make sense to me that we would see more functional symptoms for patients that are already at risk. But I agree, like, the question is overlaps / misdiagnosis. And I think that it is, I do not have a good, easy answer for that. And I think it is definitely something we should be kind of thinking about and exploring a little bit more.
Yeah, Laurie or Nicole, I know with 2 minutes left, any other questions in the Q&A that sort of jump out at you that you wanted to make sure that we addressed? I am sort of copying all the questions down, so we will try to maybe put a Q&A section on our website in the future to answer some of these questions or reach out to people, because a lot of good points.
I think the only thing that I would add is I think that the more times that we have the opportunity to do training, to speak with colleagues, to speak with trainees, again, to trap somebody in an elevator, right, and just kind of share the information. I think that's how we can kind of move things forward with colleagues who may be giving biased or old information, particularly terminology, to patients. I mean, truly, if you think about it, most of the folks that are currently seeing patients have trained previous to terminology changes in the DSM, right? So that people who have trained over the last 30 years are just going on kind of what they were trained in, right? And so I think that for folks that feel comfortable, who are psychologists working with medical colleagues, to really continue to have these conversations with colleagues so that we can move things forward.
And I would also say that we're hoping to have future webinars to, in more detail, discuss some of these more nuanced questions. So today was just an introduction, just our first one. We're going to talk more about a specific treatment next time, but we'd also love any feedback about more nuanced topics that would warrant further discussion.
Yeah, we had over 430 registrants. So obviously that was surprising to all of us, but really exciting. So there's a big need for this. There will be a survey sent out, as Caitlin said earlier. So if you have any feedback, please put that in the survey or send you should have my email address. Send me an email and I can pass along to the rest of the SIG. But with that, any last words, Laurie or Nicole or Caitlin?
Just thank you all so much. This was our pleasure.
Thank you, Laurie and Nicole, for kicking off our series. We really appreciate this and we hope everyone found it to be helpful today.
Thank you, everyone, for attending.